A lot of people think expressed breast milk is same as breastfeeding. There is a difference. You can get the nutritional part of the breast milk by express milk, but you don't get the physical part of the jaw development and what the advantage of breastfeeding. So it's extremely important that you breastfeed, not just express breast milk.
Hello, welcome to Breath, the new science of a lost art expert Q&A. Today we are going to be talking about infant breathing, snoring, sleep apnea, SIDS, and more. The expert today is Dr. Umakanth Katwa. He's an instructor of pediatrics at Harvard Medical School and an attending physician in pediatric pulmonary and a sleep specialist at Boston Children's Hospital. He's the director of the sleep laboratory at Boston Children's Hospital and an expert in breathing and sleep disorders with particular interest in infants. His areas of research include phenotyping, pediatric obstructive sleep apnea, central sleep, and other sleep-related breathing disorders. The first question, is any sleep apnea normal in an infant? Is any snoring considered normal? Dr. Katwa?
James, thank you for having me. Before we talk anything which is normal, we have to understand what does sleep apnea actually mean. Is there something called normal sleep apnea? So when somebody uses the term sleep apnea, and for a specialist, I'd like to know more. I like to see whether it is a central sleep apnea or normal respiratory pauses, which are common in babies, especially particularly in the first few months of life, or obstructive sleep apnea. And again, some degree of obstructive sleep apnea may be acceptable, but how bad it is. So for that matter, when somebody says sleep apnea, I need more information. So I go and ask more history and find out. To understand a little bit more about sleep apnea, we have to understand how does the normal baby breathe. So for that, a baby after birth, a normal term baby, the breathing is quiet. If there is any noise or any stridor, depending on what it is, if it's persistent, needs to be evaluated. Infants are obligated nasal breathers. They breathe by nose. By breathing nose, because of the nasal receptors, when the air flows through the nose, it stimulates the respiration. So a baby breathing by the nose has a better respiration than the baby breathing by mouth. The nasal resistance improves the respiratory muscle resistance training, like exercise, so that the muscles develop, the breathing muscles develop very well. There is a variable effort. The infants have a variable respiratory effort, so that every time the baby breathes, the respiration, the amount of air it takes in can vary, particularly in REM sleep. The baby breathes faster because the lung volume was smaller. They can't take a bigger breath, so they need to breathe faster to meet that oxygen demand. They have also a low volume I talked about, and they take frequent sigh breaths so that they can open up the lung volume so that they can maintain the oxygen capacity. And some central pauses are common. So this is a cartoon showing normal breathing patterns in babies, the top one. Below that is a periodic breathing or a central pause. These are pause followed by an effort, followed by a pause and an effort. So this is we commonly see in infants. And then followed by, you see those tiny pauses, which is called central pauses. If you see a baby and you notice those pauses, you may suddenly feel the baby is not breathing. In that situation, these are normal. Again, a sleep study helps to pick up whether it's a normal breathing pause or an abnormal breathing pause. So again, and the fourth image, which you see down here, is an obstructive breathing. The baby is breathing, but there is no flow of air in the nose. So again, these are various patterns. It could be abnormal to mildly abnormal to pathologically abnormal.
Great. Thank you. Is there any research looking into a mother's breathing, such as overbreathing or CO2 levels, and how that might affect the infant? I'm guessing the baby will have the same environment as the mother, since blood flow is the same through the placenta.
This is a very, very interesting area of research. There is some old research, but a lot of people don't pay attention to maternal breathing and impact on the fetus. So normally, when a lady is pregnant, her basal metabolic or oxygen demand goes up progressively through the gestation up until term. By the end of the first trimester, your oxygen demand and carbon dioxide production goes up by 30 to 40%, and it dramatically increases by labor. So to meet that demand, the mother's respiration goes up. Because of the pregnancy, she can't take very big breath, but definitely the tidal volume, the amount of breath which she takes, goes up by 30 to 40%. Even though the respiration remains same, she breathes faster to get more oxygen. So when you breathe faster, for example, if you hyperventilate, your carbon dioxide goes down. So normal person, the carbon dioxide is between 35 to 45 millimeters of mercury. In pregnancy, the normal carbon dioxide is between 28 to 32 millimeters of mercury. So that gradient across the placental blood, the fetal carbon dioxide is higher than the maternal carbon dioxide because the fetus also produces carbon dioxide. So that helps to diffuse the carbon dioxide from higher fetal gradient to the lower maternal gradient, so the carbon dioxide can be excreted from the fetus into the maternal circulation and can be excreted up. So this gradient works well in fetal advantage. But if mom tends to hyperventilate more because of any issues, because of anxiety or any other respiratory problems, her CO2 can go further down. So when that happens, if the CO2 goes down very low, that can invariably have an effect on the gradient across the fetal circulation and can affect cerebral oxygen of the mother. So if it goes too low, it becomes a detrimental effect on the fetal oxygenation and can have adverse brain development problems in future.
My infant snores, this is the next question, and sounds like he's holding his breath while he sleeps. What is causing this?
So infant snoring can be because of multiple reasons. And the second question is pausing breath. So infant snoring can be because of nasal congestion. It could be because of secretions in the nose or because of the narrow nasal cavities or passages. It could be because of any growth in the nose, or it could be because of any floppy airways or any airway lesion. In an attempt to identify how this progresses over time, if the snoring is pretty persistent, loud, and persistent throughout the stages of sleep, then it needs evaluation. If you put some nasal saline drops and clean the nose and the secretions come down, then you don't need to worry about it. Sometimes the noisy respiration gets worse during sleep. Those needs to be evaluated. Sometimes they get better during sleep. They may not need to be evaluated because floppy airways then sometimes gets quieter during sleep. So again, a noisy respiration needs attention, follow-up, and if it's persistent, needs to be checked by a specialist. For example, a pause, as I told you in the first couple of slides, a normal pause is a part of a normal respiration in babies. We don't do anything. That's a maturational progression of the respiration during early neonatal age. But if the pauses are long, are associated with color change or non-responsiveness, or they're repeated, they definitely need to have attention and seen by a physician.
Next question here. Is a polysomnogram necessary to diagnose infant sleep apnea?
Yes. Clinical symptoms of sleep apnea can be mixed, and sometimes we may not be as good as picking up the severity of sleep apnea. Normally, a sleep apnea child has stridor or snoring. They can also have mouth breathing. They can have indrawing of chest. They can have poor weight gain, or because they are breathing against an increased resistance, they may have sweating on their forehead because they're working hard to breathe. They may have feeding difficulties, particularly during sleep, because they are breathing against the blocked airways. Sometimes they may present in clinics, like the mom noticed the infant was unresponsive, what we clinically call as an apparent life-threatening event. And mother rapidly stimulates the baby, does mouth-to-mouth respiration, and may show up in an emergency room. If it is untreated for a long time, they may have developmental delays. So clinically, we can suspect this patient has potential sleep apnea, but how do we prove it? To prove, one, to confirm the diagnosis of obstructive sleep apnea and differentiate obstructive from central sleep apnea, and to assess the severity of the sleep apnea, we have to do a polysomnogram. So here is an image of a polysomnogram, which I'm going to play. The baby is in the left upper hand corner, sleeping comfortably, and you see this respiratory effort, but there is no airflow. You can see that, and if you can pay attention, you can clearly hear a snoring sound and then snort and arousal because of the opening of the airway. And these episodes you can see are associated with drop in oxygen from 96% to up to 80%. So these episodes, if they happen repeatedly, that's how we evaluate and diagnose sleep apnea.
What is the best sleeping position for an infant who snores?
For any infants, the best sleeping position is supine. These recommendations come from the American Academy of Pediatrics for the safe infant sleeping practices. if you look at the history of the SIDS, the greatest impact on the incidence of the SIDS with the reduction was because of the back to sleep campaign. And the second was breastfeeding. So, as we know, once the infant is diagnosed with sleep apnea, that needs evaluation and treated. What is the cause of sleep apnea? If the infant has stuffy nose or noisy respiration, irrespective of whatever it is, the baby continue to sleep on supine position unless as recommended by a physician to sleep in a particular position. Without a particular recommendation, the baby has to follow the safe sleep practices, which is recommended by the American Academy of Pediatrics, on a firm mattress with the mattress firmly tucked in without any soft toys or any articles, items where the baby can suffocate and results in an unwanted event.
Is there any relationship between SIDS, sleep apnea, and upper airway resistance syndrome?
Yes. So obstructive sleep apnea is listed as one of the cause of sudden unexpected infant death. A SIDS is defined as when you have a baby who died and after thorough investigation you don't find a cause. If obstructive apnea is listed as a cause of the death, then it is classified as a sudden unexpected infant death, or SUID. That's the difference between SIDS and SUIDs. So when you know the patient probably had died, and there was a study by Dr. Guilleminault from Stanford in 2012 where he reviewed about 6 or 7 infants who had died of SIDS and went back to their postmortem report, and they found that those infants had a high risk of high arched palate, mandibular retroposition. Some infants even had enlarged tonsils at such a young age, and they had diagnosis of OSA. By itself, obstructive sleep apnea will not cause SIDS because there are a lot of infants who have obstructive sleep apnea. For about 1 to 2% of the infants can have obstructive sleep apnea. But the incidence of SIDS is about 1 in 100,000. So there has to be a perfect storm that normally when the baby's airway obstructs and the oxygen goes down, sometimes the baby wakes up, turns the head, and tries to breathe again. So the arousal mechanism, which is a protective mechanism against an obstructive airway, keeps the respiration going. For some infants, when this robust arousal mechanism, which is a protective defense mechanism in the body, is abnormal because of some chemical imbalances in the brain, which is mediated by serotonin, those infants may not sense the rise in CO2 or drop in oxygen because of the apnea, and then they continue to be like sleeping throughout this apnea, and that hypoxia can result in a cardiac arrhythmia, which results in death in these babies. So it is very difficult to go backward and find out what exactly happened, but you can clearly see some telltale signs of obstructive sleep apnea. That was the reason the baby died.
Can you talk a little bit about, and this is a question I've received dozens and dozens of times, is mouth breathing in infants, is it bad? And if so, what can we do?
So this is a question I also get a lot of times when I see, and I have a little bit of a take on this one. So there is a difference between open mouth posture and a mouth breathing. A baby may have an open mouth posture, may not necessarily be mouth breathing, and mouth breathing can happen in normal infants very briefly. If you notice a little bit of mouth breathing, that is not necessarily abnormal. If the baby has a persistent mouth breathing, then it is a problem. So now, to what extent it is normal? There are studies people have done it in preterm infants. It is slightly higher than in term infants, depending on the stages of sleep. For example, in REM sleep, as the muscle tone relaxes, the jaw may drop a little bit. So even though the jaw may drop and may appear apparent like a mouth breathing, the infant may actually be nasal breathing. So how do you differentiate that? If you put a CO2 monitor in front of the mouth and it picks up some CO2 values, then you may see that some air is passing through the mouth. Some babies may be breathing predominantly nasally, a little bit by mouth. So there can be still a mouth breathing doesn't necessarily mean that the mouth breathing 100% of the time. The air is moving through the mouth. So again, these are the factors we need to take when making a decision. So about 10 to 12% of the babies through the sleep of the total sleep time can be mouth breathing. So what are the causes of mouth breathing, which is persistent mouth breathing, what I mean? So the persistent mouth breathing is predominantly more than 50% of the time the baby is breathing through the mouth, or more than 40% of the time if there is a nasal obstruction, either anatomical or secretion for whatever reason. And those infants tend to have predominant mouth breathing. So that needs to be evaluated. Once you take the obstruction out, mouth breathing gets better. Number two, low muscle tone, like premature babies or babies born with reduced muscle tone for various reasons. Because the jaw muscles are weak, they may drop open and the baby can start mouth breathing. Third, for whatever reason, if the baby is intermittently mouth breathing initially, then becomes much more persistent, the nasal obstruction develops and the nasal obstruction goes away, but it becomes habit. Then it called habitual mouth breathing. So when there is a habitual mouth breathing, the baby identifies that the nose is a little bit harder to breathe and mouth is easier to breathe, and then it persists. So there are various reasons, and at various point in time, there can be various risk factors. So the risk factors for mouth breathing are prematurity, nasal obstruction, as we discussed. Bottle feeding is associated with high risk of mouth breathing. This has been shown. So for that reason, breastfeeding is helps to treat mouth breathing. If somebody comes and tells me like, how do I treat? And you see these people are bottle feeding, I just said, if you can breastfeed, that's great. But a lot of babies come after the parents have stopped breastfeeding for several months. The next is softer diet. Babies are using these baby formulas, which the baby hardly chews. So again, using a little bit of a consistency helps. And tethered tongue tissues has been reported, particularly with severe tongue ties. The tongue can not rise to the floor of the mouth, as a roof of the mouth. That can cause mouth breathing. And sometimes a normal or a small size mandible, which is retroposition, which cannot completely close, can result in mouth breathing. So these are some of the risk factors. So how do you treat it? What do you do about it? First, if it's persistent, you should definitely have to get it checked for any obstruction because you need to see an ENT or a pediatrician. Number two, I encourage breastfeeding. So the breastfeeding has to be started and has to be told right from beginning. A lot of people think express breast milk is same as breastfeeding. There is a difference. You can get the nutritional part of the breast milk by express milk, but you don't get the physical part of the jaw development and what the advantage of breastfeeding. So it's extremely important that you breastfeed, not just express breast milk. Obviously, treat the obstruction. If there is a significant tethered tissue causing feeding difficulties or breathing difficulties, you should address that with your pediatrician. Myofunctional retraining for the weak muscles. There are different devices people use for babies. They can help to train the jaw. And obviously, you should pay attention to what the baby is eating. When you're weaning from bottle or from breast to a regular diet, you should keep some consistency where the babies can chew and swallow and helps with the jaw development.
Next question here. What role do tethered oral tissues such as tongue tie play in infant mouth breathing?
So this is, in a way, a controversial topic. A lot of people have a different and strong opinions. It depends on whom you talk, versus um, dentist versus ENT versus pediatrician versus myofunctional therapist. Everybody has a take. I think when people have a different take, I think the answer lies in the spectrum. That means everybody is partially true and everybody is partially wrong. So we can't generalize a milder version or we can't underplay a severe tongue tie as absolutely nothing. So we need to be very careful about what we say and how we approach. You don't need to take approach all or none. Not that I'm going to not treat all the tongue ties or I'm going to treat every tongue tie in this world. So every tongue is tied. I mean, the tongue is attached to the floor of the mouth. The idea is to keep the tongue in position. But sometimes because of developmental issues or whatever it issues, the tethered tissues can be a little bit more, which affects the mobility of the tongue, right? So initially the role of the tongue is swallowing. If that is affected, definitely it needs to be addressed. Number two, breathing. And the position of the tongue on the roof of the mouth is extremely important for the craniofacial development. If that is affected, it should be treated. If the tongue interferes with the breathing part, it should be treated. And again, I would leave it out of this discussion to what extent they treat because it is a clinical judgment. It is very confusing for a layman. That's where a person who's experienced in these aspects is extremely important to identify the limitations, the pros and cons of any intervention. If there is a dysfunction because of the tissue, it should be approached. Um, in my opinion, if there is a tongue tie, it's unlikely to cause a severe obstructive sleep apnea early in infancy. In the first, it can cause difficulty with feeding. But there are some types of tongue ties, it can cause obstruction. But typically, if it's a milder version, it should not. But if it persistently untreated, it affects the craniofacial development and later it can cause sleep apnea, not necessarily at the beginning. So that's the thing we should worry about. So in addition to the tongue tie, if it is severe, there can be other facial tissues which are attached to the tethered tissue, which can be tensed up. And there can be some compensatory changes with the neck position, with the head position, with the mouth posture. And ultimately, sometimes I see some of the people say, and the parents say to me that after the tongue tie release, the infant's position, the crying, or the posture has improved. Yes, those are the babies probably had some type of tissue, and that needs to be assessed. So in that situation, a tongue tie is just not a tissue attached to the floor of the mouth. It is the patient as a whole, how it is affected, how it affects the function, feeding, breathing, and the posture.
Dozens and dozens of times readers have asked me this question. I didn't know how to answer it, so I'm hoping you can provide a little context here. It is, how would breastfeeding possibly improve breathing in infants?
So breastfeeding, breathing, and craniofacial development are part of the same spectrum. And breastfeeding is there for a reason. And infants who are breastfed compared to the bottle fed have a better and stronger jaw, better orofacial muscle tone and strength, and better parallel arch development. So infants who tend to bottle feed tend to have a slightly high arched palate compared to the ones with the breastfeeding. It helps to improve your suck, swallow, breathe coordination, which is an extremely important function. If you look at that, for example, like you and me, when we are swallowing, we can't talk, we can't breathe. We need to pause to swallow. But infants, when they are breastfeeding, they continue to breathe through the nose and they figure out in a way they can squeeze in some portion of swallow while they're breathing. So here is a diagram I'm showing you. The top corner of the diagram is a suction pressure. The baby is sucking, and you can see these movements of sucking. And below, there are some waveforms which is labeled as breath. These are breathing mechanisms. And there are some waveforms which are reported as swallow. So the baby figures out a couple of swallowing while the baby is breathing and sucking. That suck-swallow coordination is extremely important. For example, when the baby swallows, as the baby is not sucking at that time, the milk does not come out. So the baby will not aspirate. For example, if the baby is bottle feeding and try to swallow, if the milk is coming out of the bottle freely, it can choke and it can close the glottis. When it closes the glottis, it causes an apnea. So while the baby is bottle feeding, there is slightly higher level of oxygen desaturation on some of the studies done, which causes issues with brain oxygenation. But again, this is not common, but especially in the babies who are a little bit preterm and who are trying to feed, I've seen babies having some desaturation. Most of the parents don't measure saturations, or they don't have the sensitive oximeter to check the milder degree of desaturation, so you may not pick up these things. But there are studies clearly showing that the frequency of desaturation is much higher in the bottle-fed babies than in breastfed babies.
Could you just describe for the readers who aren't familiar with that term desaturations, exactly what that means?
The desaturation is a medical term used for a drop in oxygen for more than 3 to 4% from baseline.
Okay, thank you very much. That is it for this round of the expert Q&As of Breath, the New Science of a Lost Art. I would like to thank Dr. Katwa very much for his time and answering all of these wonderful questions. If you want more information or further Q&As with other experts, you can visit mrjamesnestor.com/breath. Thank you, Dr. Katwa.
Thank you. Thank you very much for having me.